The surgery of the aortic arch and the thoracic aorta continues to be associated with a significant mortality. Neurological complication rates can vary considerably depending on the cerebral protection, technique employed, patient-specific characteristics, clinical presentation, and the experience of the surgical center. A multidisciplinary approach is considered fundamental for comprehensive patient management. Neurological complications are primarily represented by the postoperative stroke, postoperative cognitive dysfunction, paraplegia, and spinal cord ischemia. Because of this complication can be traced to cerebral embolization, hypoperfusion, hypotension during circulatory arrest, and cerebral perfusion, Hyperperfusion, and systemic inflammation. How can implement strategies to minimize these possible complications, especially in complex aortic procedures? First, careful planning for elective procedures is essential to build a cohesive team between the surgeon, perfusionist, the nurses, and the surgical technician. While it is not possible to prepare intense in same for emergency, regularly discussion for elective case helps strengthen the team, making the responses to critical situations smoother and more automatic. And next, great preoperative diagnosis are essential for surgical planning. The thoraco-abdominal angiosynthesis scan, preferably ACG gated, is the reference examination in both emergency and elective setting, offering a detailed assessment of the vascular anatomy of the entire of the aorta. Optimizing the operating room requires careful organization, cerebral monitoring with the NIAS, EEG, and when is possible the transcranial Doppler. Tools such as Röntgen and Doppler flowmetry are essential. Another crucial point, the choice of the surgical strategy. Premise, hypothermia play a crucial role in a complex surgery. However, the literature highlights the three main challenges. Variability in measurement methods, lack of a uniform definition of hypothermia, and variability in circulatory rest time. As mentioned, we needed to use a standardized classification to define and categorize hypothermia. Below is the classification we have adapted based on the international guidelines on the cardiopulmonary bypass in adults cardiac surgery, ACTS and SCTS. Surgical approach. It has been shown that the deep hypothermic circulatory arrest provide the weight, brain, and organ protection up to a rest period about 30 minutes. The use of the high moderate hypothermia with antegrade cerebral perfusion is emerging as the preferred strategy for the aortic arch surgery. It allows for an extended circulatory rest period of over 90 minutes. The advances include reduced coagulation impact, improved neurological recovery, resulting in better outcomes without the adverse effect of the deep hypothermia. A fundamental aspect to consider in antegrade cerebral perfusion is the flow rate in the perfusion pressure. This raises the question, what is the ideal flow rate? according the aortos such as we Tian Olson, during unilateral antegrade cerebral perfusion, a maintained flow of 8 to 10 millimeter per kilogram per minute is considered the way provided the circle of Willis is intact. However, if the circle of the Willis is incomplete or carotid stenosis is present, bilateral perfusion is recommended with a maintain the flow about 10 to 15 millimeter per kilogram per minute. Effective monitoring during antegrade cerebral perfusion include pressure, cerebral oximetry, and a more advanced setting, the transcranial Doppler. Another possibility is a retrograde cerebral perfusion. It involves perfusioning oxygenated venous blood through the sagittal sinus via the superior vena cava. An ideal flow rate of 200 to 500 millimeters per minute is used to prevent endothelial damage and ensure effective perfusion. It's very, very important to monitor cerebral venous pressure during RCP. At our center, we have chosen high moderate hypotensive circulatory arrest and integrated cerebral perfusion. And our CPP circuit is specifically designed to ensure safety and efficacy during circulatory arrest and selective perfusion of the supraortic vessel. The setup includes a 3-inch tube directly blood flow to right axillary artery. Another 3-inch tube for the systemic reperfusion or femoral cannulation if needed. Y connector 3A 1/4 integrated into the circuit, a 1/4 inch tube dedicated for selective cerebral perfusion. This is our setup: isolation and cannulation of the right axillary artery, achieving of a body temperature range between the 25 to 27 centigrade, cleansing of the brachiocephalic trunk, and the perfusion through the right axillary artery at approximately 7 millimeter per kilogram per minute. When possible, selective perfusion of the left carotid artery, adding a supplementary flow at 1 millimeter per kilogram per minute. Monitoring of cerebral oximetry and the management with a single roll. This configuration simplifies flow control and ensure optimal blood distribution. And a fundamental aspect of antegrade cerebral perfusion is the control of the flow and the perfusion pressure. To this end, we are measuring the flow in the left carotid artery and when possible also in the left subclavian artery before the circulatory arrest. The obtained flow is then replicated during antegrade cerebral perfusion. However, additional data and a lower case series are required to draw more definitive conclusion. When we have tested the DCT and found that an adequate calibration process, experience and training are necessary for optimal use. This is our example for our operating room setup for cerebral monitoring. At the end of the procedures, we check the flowmetry of the debranching procedures. In conclusion, I believe it is essential and highly beneficial to promote the surgical training for young surgeons using the 3D technology from 3D printing protection and more broadly of medicine and surgery is closely linked to technological innovation that integrate the virtual reality and the artificial intelligence. This should be combined with advanced cerebral protection devices and the development of personalized therapeutic pathway aimed at optimizing clinical outcomes for each